Next up, I'd like to introduce the team joining me today. First up, we have Heather Osborne. Heather is Thrive Tribe's lead dietitian for weight management and diabetes prevention, and we'll be speaking to you shortly about our programme. We have Andy Emerson, our head of service delivery, who will be accountable for our operations in Cornwall. And we have Dr. Richard Pyle, Thrive Tribe's lead GP, who will be speaking to you in a minute, all about preventing diabetes in primary care.
Thank you, Tim. Welcome, everyone. I just thought I'd start by introducing myself. My name is Richard Pyle, and I'm a GP partner in Hertfordshire. I'm a specialist in cardiology and lifestyle medicine, and the Thrive Tribe lead clinical GP. A passionate advocate of lifestyle medicine. I'm also what was our CCG's lifestyle medicine and prevention lead, and hopefully I may have a job in the ICS. Who knows? Depends whether your ICS is as organised as ours is. And today I'm going to be talking about the difference that preventing diabetes makes to patients, to practices, and to our system. And you'll be pleased to hear actually that I'm not going to be showing you loads of slides. The only downside of that is that you're stuck with my mug on the screen, but I think that sometimes people do turn off, so hopefully just me talking in an animated and interesting way will be enough. And I thought I'd start by looking at where we are now. So this is kind of the doom and gloom slide. In the UK at the moment, we've got over 4 million people with diabetes. We think by 2025, according to NICE, it could be 5 million. And 90% of people with diabetes have type 2 diabetes. It's thought actually, and this shocked me, but this was a BMJ article 8 years ago, that a third of UK adults are pre-diabetic. And we know that type 2 diabetes costs the UK probably about more than 10 billion a year. That's before you start, that's purely to the NHS actually, that's before you add in the social costs and the other associated societal costs of diabetes. And of that 10 billion, at least 2.5 billion is spent on drugs, both diabetic drugs and non-diabetic drugs, for all the complications. And we know that, I know that there are people in this room who are GPs and from other parts of primary and community care. We know that the care system is massively overstretched, including primary care. Patients often feel abandoned. There have been surveys done by there was a study in the British Journal of General Practice which described patients as feeling abandoned. They weren't getting the care that they once got from their GPs when it comes to their long-term conditions, including diabetes. And we know resources are limited, and so we risk providing adequate but not excellent care. And these situations are likely to only get worse in the next few years. 10 to 19 patients in primary care per year are used for diabetes related issues, depending on comorbidities. And we know that GP practices get paid maybe £100, £150 a year for doing that. And so there are costs, of course, to the patient, physical, mental, and financial. And if I had a slide, I'd be at this stage, I'd be having the, why doing nothing is not an option here, but that would just be a big picture of Jim Carrey probably going, duh, clearly doing nothing is not an option. So we need to think about, what we can do better. And we know prevention is so much more achievable. It's not just better than cure, it's more achievable than a cure. To slightly misquote the Blur album title, modern medicine is rubbish, or I should say mostly rubbish, when it comes to long-term conditions. Yes, we save people's lives and we chop out cancer and treat awful autoimmune disease, but the fact is when it comes to long-term conditions, the honest truth is that most drugs we prescribe, including for diabetes, they're not to cure people, they're just for symptom control. And even then it's marginal. And we know about the numbers needed to treat for a lot of drugs that we prescribe for long-term conditions. You have to treat 100 people with a statin who are low risk to have one of them not have a heart attack, 150 for one of them not to have a stroke. We know that actually tight glycemic control in diabetics, sadly, does not prevent death or stroke or MI or kidney failure, and maybe it reduces amputation in 1 in 250 patients. But my point is that once you've got diabetes, it's very difficult to turn that around. And yet we know that the numbers needed for weight loss to prevent diabetes are actually really low. You only have to have 7 people lose weight for 1 not to become diabetic, 13 for hypertension, and 14 not to have lifelong disability. And those are incredible numbers needed to treat. If a pharmaceutical company had made a drug that was capable of that, they'd be trumpeting it from the rooftops. And we know that a very low carbohydrate diet for the remission of type 2 diabetes can be helpful, whether it's new or long-standing. But of course, ultimately, it's much better not to have it in the first place. So the National Diabetes Prevention Programme was established in 2016 as a joint initiative between NHS England, Public Health England and Diabetes UK. And my colleagues at Thrive Tribe are going to go more into the nitty-gritty, but just to highlight a few of the key issues, it's for adults with pre-diabetes or non-diabetic hypoglycemia, and people who've had gestational diabetes and are now normoglycemic. It's a 9-month programme, and it supports weight loss and or improved HbA1c, and we know that of course the two aren't necessarily exactly the same. Outcomes, there is good outcome data for the NDPP. It was a research data published in 2020 showing an improved HbA1c reduction and a weight reduction compared to other pragmatic sort of weight management and lifestyle programs. And it is suggested, of course, it's still early days yet, it's only 6 years, but it is suggested therefore that we are looking at likely future reductions in type 2 diabetes. And Thrive Tribe, as Tim has mentioned, are the new NDPP provider for Cornwall from this August. And they have a great record as a provider with a strong emphasis on behaviour change, which I think helps to differentiate us perhaps from other providers. So the question is, how do we do it in practice as GPs, as primary care people, as nurses, as care coordinators? And really what we need to have is good quality conversation. So clearly we would encourage you, when you're sitting with your patients, and it comes up, whether or not it was on their agenda to start with, to have that conversation about the raised HbA1c and to consider whether you might refer them into the service or whether the patient might like to self-refer. I think referral is definitely by the GP or health professional, sends a very strong message about how important it is. Of course, that's quite a targeted approach. You may also consider, you could run a search in your practice. You already do this, don't you? Because you know who've got non-diabetic hypoglycemia. But I don't know about you, but lots of those patients, when I've looked at them, actually haven't historically been offered the National Diabetes Prevention Programme. So there's a big cohort of patients out there that you could search for. It's an easy administrative task. You've already got the searches in your system. And then they could be sent a message, whether it's by Accurix or whichever other third-party softwares you use in your practice, to invite them to explain the problem, invite them to consider the NDPP, and then either include a link for self-referral or invite them to have a conversation with the practice. Now, I'm very much aware that clearly we're under huge strain at the moment and there are significant workload implications, and it's wonderful, isn't it, when other people who are not GP surgeries come along and say, here's a great thing that you should do that's for patient benefit, add it to your list, it's another thing you haven't got time to do. But of course, it doesn't need a referral from a doctor as such either. Within your practice, you'll have nurses and care coordinators, social prescribers. You could have someone appointed within your reception or admin team who is the point of contact for when patients ring back to ask about the NDPP. And as long as they've been primed with the right information and they can have a brief conversation with the patient, then that's all that they will need. And it is worth pointing out, of course, although we know you're not in it for the money, but it is worth pointing that £11.50 is the fee that's paid for every referral into the National Diabetes Prevention Programme for patients who then engage with the programme, in the same way that you also get paid for referring to Tier 2 services and the National NHS Digital Weight Management Programme and Tier 3 and 4 services as well. So the question is, what future do we want? Well, let's start with our patients. That's where we should always start. Less disease, fewer complications, a longer lifespan. I think more importantly, a longer health span. We know that in some parts of the country, there's an 18-year disparity in healthy lifespan between the most fortunate and the most disadvantaged. And of course, the consequence of this will be, if diabetes can be prevented, improved physical health, improved mental health, less time spent in appointments, less time requesting drugs, collecting drugs, taking drugs, monitoring drugs, and giving the patients a sense of empowerment and control. And we know that for patients to really make changes in their lives, you do need that autonomy, that sense of control that comes with, as well as being helped by their professionals. What future do we want for practices? Well, if our patients are happier, we're going to be happier, aren't they? I mean, I don't know what it's like in your practice at the moment, but lots of our patients are not very happy. And in turn, that has a knock-on effect upon everyone that works in the practice, from the person who answers the phone in reception right through to the partners and the practice manager. It will, of course, in the long term mean you've got greater capacity for appointments, because you won't need as many people to be coming into the surgery for their diabetic reviews. And therefore it does mean a reduced workload, reduced repeat prescribing, which of course is a tremendous burden as well. A lower drug budget. I know at the moment drug budgets don't necessarily come out of practice pockets, but if we look at the work that's been done by people like Dr. David Unwin, the low carb GP, he's saved tens of thousands, I think approaching £100,000 on his practice budget through reversing diabetes alone. And I heard him speak last week, and I think they've now had over 120 people who are no longer diabetic and pre-diabetic. And of course, doing these things frees up resources for other things as well, and which means a better quality of life for all of us who are also health professionals. I think it's important we're honest about that. Better life for our patients, better quality of life for us. And of course, it's a marginal gain. You won't see an immediate result. But as most of us know nowadays, when it comes to dealing with the significant challenges that we face in the NHS, and particularly in primary care, there are no magic bullets. All of these are marginal gains. So this is yet something else that can help us get towards where we need to be. And what future do we want for our system now we move into the brave new era of integrated care systems? Well, for our health and social care system, clearly a reduced burden of disease, reduced prescribing costs, reduced attendance at hospitals acutely, reduced admissions to hospital, and generally, an improved outcome for everyone right across the system. So that's why I want to heartily encourage you to be proactive in referring your patients to the NDPP. Thank you.
Thank you, Richard. And if anyone's got any questions for Richard, we'll be coming back to some Q&A after everyone's done their talks. Now I'm gonna pass on to Heather Osborne, Thrive Tribe's lead dietitian for weight management and diabetes prevention. So over to you, Heather.
Thank you. Hello everybody. So I'm going to talk to you a little bit about our programme, what makes our programme different, hopefully why it works, and kind of some of the key principles as well. So it's a 9-month programme. The way that it works, it's either group sessions that people can come along to. Groups usually set at about 20 people. There's going to be group sessions running across Cornwall in all different regions once we have sort of enough people in one area to run a group, or alternatively virtual group sessions will be running as well. So people can come in person or online. But we look to, as part of the group sessions, address all aspects of lifestyle medicine. So it's very much a holistic approach where we're looking at not only nutrition, but also physical activity, but also people's well-being and mindset, sleep and alcohol. And I think, like Dr. Richard Pyle mentioned there, it's very much based on the principles of behaviour change. And our main aim of the programme is for clients to reduce their body weight by 5%. So, but what we know doesn't work from our experience of running other weight management programmes is, through just sort of telling people what to do or just giving advice. That doesn't work. We want people to make long-term sustainable changes. And that's very much why everything we do is based on the principles of behaviour change, which I'll talk a little bit more about. We're also going to be providing some specialist programmes for clients with hearing impairment, visual impairment, women who've had a previous diagnosis of gestational diabetes, and those from a Southeast Asian background. And there's some of the target population groups for this programme. And here you can see some of the resources that we've produced to support some of these additional programmes. And we're really excited. We've got a lady called Yvonne Cobb, who is a food vlogger and blogger, and she's been on the BBC, and she's also deaf herself. So she produces recipes for clients, but they're all done in British Sign Language. So it means that people who maybe are hearing impaired, who wouldn't previously be able to access some resources like this, also have the opportunity to be able to use a lot of our recipes and resources and videos as well. So what do we believe makes us different? So the programme has been designed by a team of us from Thrive Tribe, team of experts. So we've got dietitians on board, we've got physical activity experts. Like I say, we've got behaviour change, health psychologists on board. On a number of our other programmes, we've done a lot of work with Dr. Heather McKee, who's an expert in behaviour change, and she's been able to provide us with lots of knowledge and information and really help us shape our programmes around hopefully what is going to work for clients longer term. So we use a number of principles, such as sort of setting very small 1% experiments that we encourage clients to do. So they just set themselves something very small that they want to achieve when they're, rather than setting goals, they set a 1% experiment, with the idea being, because if it's an experiment, it might go really well, but equally we recognise that sometimes things won't go well, and that ability to fail sometimes actually then down the line sets them up for better success. Also habit stacking, so building on again the principles of setting very small changes to their behaviour, but that they can then build on, and hopefully over the 9-month period, by the time they get to the end of that, they'll have actually made some quite large sustainable changes, but just by gradually building on very small changes to their lifestyle, which makes it much more achievable for clients. Our first session, so although they're group programmes, and we know that sometimes group programmes can be quite daunting for people to come along to, before somebody comes along to that group session, they will have an initial getting to know you session with a member of our staff. And the idea of that is that we can really get to know those clients. We can understand what motivates them. We can try and understand maybe what is their why, but also what might be some of their barriers. And then through working through those type of things together, hopefully we can provide them with individualised support and advice to help them change. And we've also been thinking about what support we can provide to clients between the group sessions, because it is a 9-month programme. Towards the end of the period, some of the sessions are only happening monthly, which can be quite a long time for clients to maintain their motivation and continue with the changes that are suggested. So we have support in place in the method of newsletters, emails that go out, just small text motivational messages, but also encouraging clients to get together outside of the group. So maybe use the time that they would be together in a group session actually to still get together and maybe go for a walk together or go for a coffee together. And we know that that kind of relying on other members of the group and group motivation has been shown, but there's evidence to support that that can help with health change as well. So here you can see a little snapshot of some of the resources that go alongside the programme. So we have a recipe book that probably contains about 150 recipes that clients can access. And the idea is, you know, some of them are really, really simple recipes. So they're not all kind of complicated, fancy recipes. Some of them are just as simple as maybe some a simple breakfast recipe that people can make, and some of them are more complicated and maybe a little bit more complex for people who do enjoy cooking. We also have a health journey. All our clients will get a journal, and in there it plots the health journey for them so they can see how they're moving through. And as part of the journal, there's resources in there for people both to kind of journal and document how they're getting on with their sleep, with their nutrition, with their physical activity, but also starting to understand some of the principles of things like the hunger and fullness wheel. So recognising cues for hunger and why they might be eating, and actually starting to understand some of the principles of mindful eating that can be really important for many clients. We also have videos which are going to support a lot of the group sessions, so things like a supermarket tour and an interactive supermarket tour that clients will both watch within the session, but then we'll send the links to them afterwards so they can recap. And all of our group sessions are based on very much people getting involved and it being interactive rather than us just sort of standing at the front and telling them what to do. So like I say, founded on the principles of behaviour change with the support of Dr. Heather McKee, as well as alongside a number of our staff who are behaviour change experts, very much focusing on individuals. Why, you know, what is it that they want to change? Why is it that they want to make that change? Because we know that by somebody having an understanding of their why, they're much more likely to be able to stick with a programme. We are an experienced weight management provider. We've been running weight management services for adults for a number of years. We also run Man v Fat. We also have an online weight management program. So we have lots of experience in weight management, and we've been gradually kind of revising our programs from where we see things being successful and what's working and not working. So we're constantly kind of reviewing and hopefully improving our programs. And most importantly, we really try and design the programs to be interesting and informative. We want people to come back. We want people to enjoy the sessions. We want them to you know, come back and see their other group members and report on how they're getting on and share their experiences. So that's really important to us as well. So yeah, that's everything from me. Thank you.
Thank you, Heather. Now I'm going to hand over to Andy Emerson, our Five Tribes Head of Service Delivery, who will be overseeing operations in Cornwall. Over to you, Andy.
Thank you, Tim, and afternoon all. So we're really keen to work with you closely to ensure that we maximise referrals into the programme. There are currently over 28,870 patients with NDH markers in Cornwall, and we're keen to work with you to contact and refer eligible patients into the programme. We're open for business. We're accepting referrals already. That started on last Friday on the 1st of July, and will be fully operational and contracted from August the 1st. You can no longer refer into Weight Watchers. Referrals are no longer accepted from the 30th of June, and we've pulled together a new referral form, which is now available to you. And we've also got some changes to the eligibility criteria that I'll refer to a little later. So the first way to refer is to use your clinical systems. It's the easiest way to make a referral, for example, through System 1 and EMIS. Please note that it's essential that all data fields are completed in order for us to successfully process the referral. The referral form currently is with Ardens, who are working hard to upload the new referral form to your clinical operating system. It's fine for you to stack up the referrals too. If you want to wait for the form, we can receive in bulk referrals and have the capacity to process quickly. If the referral form isn't with you at the moment and you want to make a referral, there are other ways to do that. The second way is to use your referral management website. The referral form and programme information are available on that referral management website. You can download that form from the website, complete and send to our secure NHS inbox, which is recorded on the form. Please remember we require all fields to be completed to make that referral. The third way to refer is through self-referral. The self-referral route is open now, but this pathway's availability is under review by the NHS, and we'll keep you posted on any changes, but the referral process is open and you can do that by accessing our website at www.healthieryou.org.uk. If your patient would like to find out about the programme before simply signing up, send them to that website where they can learn more about type 2 diabetes, our NHS diabetes prevention programme, and most importantly can self-refer through our simple form. As part of that self-referral form, we check their Diabetes UK Know Your Risk score. This is a tool that determines diabetes risk through a series of questions about the individual, including ethnicity, gender, obesity, family history, and their medical history. Only those with a qualifying score will be accepted. Anyone not eligible will be directed to other provisions such as Healthy Cornwall for other healthy lifestyle support and their tier 1 resource, and they can access the tier 1 resources on our website. Going to focus on eligibility. So to be eligible, people need to be 18 or over, has non-diabetic hypoglycemia identified by a blood test within the last 12 months, has a HbA1c reading of between 42 or 47, has a fasting plasma glucose reading of between 5.5 and 6.9. And if the patient has a history of gestational diabetes, then a HbA1c reading below 42 or below, or an FPG below 5.5 can also be accepted. There's some changes from the previous framework eligibility criteria, and predominantly those changes are that a mid or high level NDH reading must be diagnosed within the last 12 months rather than 24 months, which it was previously. And there are, as Heather's already identified, new pathways in place for people who are from the South Asian population, have sight or hear impairment issues, or have a diagnosis of gestational diabetes. There is some exclusion criteria. People who are pregnant are excluded if they have blood results suggesting that they have type 2 diabetes. Anyone aged over 80 without prior risk consideration for the risks and benefits of a programme are likely to result in weight loss for those individuals. People who have had bariatric surgery within the last 2 years, and somebody who has a diagnosed active eating disorder. So we'd really love you to, as the slide says, make a referral. So please spread the word with Ella. Would you mind going to the next slide, please? Thank you. So spread the word with your colleagues. We need your support and commitment to increase the number of referrals to the NHS Diabetes Prevention Programme in Cornwall. If you refer them, we'll support them. Let's work together to make sure that we can prevent type 2 diabetes across Cornwall. Richard's already highlighted a couple of reasons why you should do this. In the short term, you can claim that £11.50 per referral through the enhanced service specification. And in the longer term, it will improve the long-term health of patients and prevent additional health complications for them, which means that they are less likely to book in to see their GPs. It'll save the footfall in your surgeries and will save both on time and money. So what should we do now? We are here to support in any way that we can. We can help by providing personalised progress reports around your referrals and referring potential attending. We can come and attend clinic meetings with you, and we would really be looking forward to coming out to some outreach events to speak to healthcare professionals and your patients, and anything else that you would suggest that you think would be of value. So let's start that conversation. There is an email address available now. Contact us at hello@healthieryou.org.uk to start that conversation with us. We'll follow up communications by sending out all of today's slides, including our contact information to all that's present at the webinar today. And the last slide, Ella, please. So if you found this webinar useful and informative, please do recommend it to your colleagues. We have 2 further dates available, and even if they can't attend, if they sign up, they'll actually receive a copy of the recording that we're making of this meeting right now. We're super committed to delivering from highly accessible venues where we can. If you are able to accommodate or host us to deliver one of our sessions, or you have any great links within your community that can support that, we'd love to hear from you more. Okay, Tim, I think I'm going to hand over to you for questions.
Thank you, Andy and Richard and Heather. I hope everyone found that useful. We're now also going to introduce you to our colleague from the NHS, Tracy Barter. Tracy, I believe we're going to see you shortly. Hello.
Yeah, hi there.
Hey.
Hello.
Welcome, Tracy, and thanks for joining us.
Thank you.
For those of you who don't know, Tracy is the project lead from the Cornwall and Isles of Scilly integrated care system. But feel free to say anything else about how you relate to this project, Tracy.
Yeah, so I guess, super excited to be working with Thrive Tribe. It's very much my role to be working as part of the team to make sure that this offer is offered across Cornwall and Isles of Scilly. We've got some really challenging referral and activity targets, I think, to achieve. But I've been really impressed with the engagement that we've had so far from primary care. And we are, we're in a position where we've got some, some really large PCNs that are working with us to hopefully start, looking at how we can implement this offer county-wide. But yeah, is super excited to be working with the wider team. But I think equally, just please reach out to these guys. It would be great to have discussions with you within your practice, within your primary care network, but equally if you're working across the system. This is a really valuable programme to be offering people that are at risk of developing type 2 diabetes, and we'd welcome having that initial chat with you.
Thanks, Tracy. I think it's true to say that the only way we can impact on the prevalence of type 2 diabetes in Cornwall and the Isle of Scilly is working in partnership. This is definitely something we'll be doing together, us from Thrive Tribe on the front line delivering the service. Tracy and colleagues from the commissioning teams are helping drive this forward with us, and you guys out in primary care talking to your patients and making the referrals. So now's the time. If you've got any questions, we would love to answer them. We've got one already from Heather from the Brannell surgery. Do patients with a history of gestational diabetes have a time frame limitation? The answer to that is no. So if there's any history of gestational diabetes, they can be referred into the service regardless of their current blood readings. That was quite straightforward. Pop any questions you've got in the chat and we'll endeavour to answer them. We'll just see if anyone's got any questions or if it's all been super clear. Also interested to see any comments you might have in the chat about your experiences to date with type 2 diabetes patients or people with oh, here we go. A comment from Laura Chapman. Julie Pollard from Volunteer Cornwall will be a good person to contact about sharing this information with social prescribers in Cornwall. Amazing. Thank you, Laura. We'll definitely follow that up with Julie. Just to let you know, we have been busy recruiting a team in Cornwall. Currently, everyone you're seeing here, none of us are from Cornwall ourselves, and we have been down and we have been meeting everyone. But over the next couple of weeks, a new team will start in Cornwall, and I'm sure they'll be out and about meeting you soon. A question from Emily from Tamar Valley Health. Is there going to be an easy referral document we can send patients like the previous Weight Watchers referral document we used previously? Andy, over to you for that one.
Yeah, absolutely, Tim. The referral document that was on screen that's being uploaded to GP systems is a quick, easy to refer document that's already been populated. It's based upon the Weight Watchers previous referral form, but it's been updated with the new eligibility criteria. So yeah, it's there, it's available, it's ready to use.
Thank you. Next question. Oh, Hannah from Royal Cornwall Hospitals NHS Trust. How many sessions are run over the 9-month programme? We've got to top them up in our heads quickly. But Heather, do you know that off by heart,
Yeah,
or do we need to top them up?
13. No, it's 13. I know them off by heart, Tim. Yeah, 13 sessions, including, so they have their initial getting to know you session, which is a one-to-one session, and then there's 13 group sessions.
Thank you. And they are slightly loaded towards the front of the programme. So they start off, I think it's fortnightly, isn't it? Then they go monthly. So there's more sessions at the start, fewer at the end. Caroline, also from Royal Cornwall Hospitals and NHS Trust, a question from our paediatric team. They transfer over their patients at 16 years. So we're wondering if there is provision for the 16 to 18 years age group, please. That might be one for you, Tracy.
Yeah, I'm unsure what your service specification actually covers you from. Is it 18 above for the NDPP?
Oh,
Yes.
it's 18, yeah. And that's
Yeah,
an NHS England spec, so I don't think we
Yeah.
can vary from that.
Yeah, no. So I think with that one, Caroline, it's probably back to, you know, flagging that back with us at the diabetes oversight group, and seeing what we can put in place for those young people, really. So just considering how we can support them in that transition. But I can pick that up with you individually.
Fab. Thanks, Tracy. And sorry we can't help there, but NHS England set the spec nationally, and it's for 18 and over. Emily from Tamar Valley Health. Oh, that's just thanking us. You're welcome. Claire from Port Isaac Surgery. Well, that must be a nice place to be based. How many locations will there be, as this stopped some people attending before? Andy, do you want to answer that one?
Yeah, we haven't got a specific number, it would be fair to say, but we're really keen to be able to run as many courses local to you as we can do. We'll need your help to do that, because we're looking to get an average number of into our courses of 20. So we'll be really happy to work with you on how we can do that. And if we can, then we would like to be able to make this as localized as we can to you. But what we can't do is have a situation where we've got 3 and 5 people in a training room. So there would be work to be done, but we're happy to work with you on localizing that service.
Thanks, Andy. Naturally, we're going to end up providing more programs in centres of population where people are kind of used to travelling to. But as Andy says, if we can get the numbers, we can be in very rural locations. It's just dependent on the numbers because it is a group set. It is a group programme. It's worth saying that the target group populations, so women with who have had a history of gestational diabetes, patients from a Southeast Asian background, and those with impaired hearing or sight, we are able to offer programs for those groups virtually online, and therefore they won't involve going to a specific place. So for those particular groups, geography won't be such an issue. Okay. That is it for now. Any more questions, do pop them on. Here we go. Emma from Petrock Group Practice. What time of day, evening do the sessions run online? There's going to be a whole range. So Andy, it's not that we have set times. It's more that you refer the people in, then we will triage the patient about what's best for them. So you won't be booking them into a specific time or whatever. You will be referring them to us, and then we're going to have people manning a phone line, for want of a better word, who will speak to all of the people being referred, talk to them, get them nice and motivated, and find out what sessions are best for them. Be that an online one, for example, if it's one of the priority groups, or trying to identify the most convenient group based on location, time, day, etc. So there'll be a whole range. Andy, do you want to add anything else to that?
No, not really, Tim, but we find in all of our services that we have a range of morning, afternoon and evening sessions in different locations. So we'll be looking at what patient needs are really, and trying to bring that all together.
Of course, we're right at the start of the programme as well. It will evolve, and we will always learn and listen. So if certain things don't work out, we won't do them again. If there's gaps, we'll try and fill them. We'll always work with you to try and work out what will work. And likewise, we'll work with Tracy to get as much local intel as possible to make sure what we're providing is going to work. We recognise that Cornwall's got certain features that make it unique around rurality and different population groups and things. So we'll always try and be amenable to that as the programme evolves. Heather, again, do you think any of us could volunteer to be test dummies? We can then sell this better if we have been attendees. That's an interesting question. We're always open, so never say no to something like that. It's not something we've been asked before, we've thought about, but Heather, I mean, Heather leads a team of people that have created the program and will be doing the training to our practitioners. I don't know what the possibilities are there, Heather, perhaps delivering at least some of it, maybe.
I think that'd be a really nice idea. We were talking yesterday actually in the group who've kind of been pulling the course together, and again models that we've liked to use in some of our other groups and some of our other areas around maybe having buddies or health champions who are kind of people who have been through a program and they understand the program, and like you say, you're much more able to support and advise somebody when you've kind of seen some of it yourself. So even if you just wanted to come along and observe some of the sessions to see what they're all about, how they run, the look and feel of them, we'd be more than happy to have you along. I think that's a really nice idea.
Yeah. I think we'll all have each other's details after today. So if anyone's, and you've got the email address that was on the presentation, so if you're up for something like that, do get in touch and we can sort it. Karina asks, what is the response time after we have referred? Our triage team tends to be able to deal with, to contact the patient after 2 working days, so it's quite quick. Obviously, if the patient's unavailable, doesn't answer the phone, etc., it might take a little bit longer, but we'll always try within 2 working days. In terms of how long it then takes to actually get on a program, that completely depends on what program they end up on, what day, what location, and when the program starts. So there may be more of a gap there. Andy, is there anything else to add there?
Not really, Tim. Triage team starts Monday, so we're inducting them and training them Monday. We hope to process any referrals that have come into the system already start mid-July-ish to do that, so that from our contract start date, which is the 1st of August, that we've got a flow of patients that we've contacted already. We've had a trickle of referrals through so far, and yeah, just to confirm, 2 working days to start that conversation around eligibility and getting to know you.
Caroline asks, will there be any provision for patients whose first language isn't English? Yes, obviously there's a wide range of languages that could be spoken, so once we know what that is, we can be amenable. The example here is Chinese. I don't think there's a huge number of Chinese speakers in Cornwall, but equally we're aware that there will be pockets. Heather, have we got any immediate plans for in this area?
We had been looking at kind of the key population groups and which languages we might need to have resources translated into the most, and the way that we've tended to do it in other areas is if we've worked with, say, a specific population group within an area, then we will get our resources and we can get those sort of, translated, and we can get on our videos, we can kind of get them not subtitled, but the different language over the top of the videos and things that we use as part of the program. So if there was a kind of key group that you'd like us to work with, we could definitely arrange that. And we do have access as well to the translation telephone service, interpreters portal, yeah. So we'd be able to use that as well.
Yeah. So definitely refer everyone, even if English isn't the first language, say what the language is, and then we will always look to find a solution, whether it's through our interpreters portal and translated documents. For example, for some South Asian languages, we will have the ability to perhaps operate in that language. So if we have a cohort of people that all speak the same language, and it's South Asian, because they're the priority group for this program, then we will be able to provide a program in that language virtually. But if it's an individual, we'll have to just be kind of flexible and be responsive. But in our wider services outside of the NHS diabetes program, we are very used to, we operate in areas like inner London, where we help people from a whole host of different ethnic groups. So outside of Cornwall, we're very used to dealing with patients from a whole different, all sorts of different backgrounds and languages. So it's more how we how we do that in Cornwall with this particular program, but we don't see any sort of big barriers there. Okay. Laura asks, is there a minimum number for the groups? Andy, is that one for you?
Yeah, we would aim to get 20 people there, Tim, because we know that there's peer support that can really work within the groups when that happens. But we don't have a lower number. But we would absolutely look to make sure that the sessions that we're looking to provide can be productive with the amount of people. Ideally, we would look for 20 a group.
Thank you. I think questions are drying up. We'll give everyone 2 more minutes to see if anything else comes through before we call it a day. This is our first webinar. We've got more to follow, as Andy said on his slide. So if your colleagues haven't yet attended, please do tell them about the next 2. We would love to see as many people as possible from across primary care in Cornwall and the others, Scilly, taking part in these. Nothing better than hearing it from us rather than any other way. Okay, looks like that might be it. So thank you so much everyone for joining us. We know how busy you are in primary care, but hopefully that was helpful, and we'll be seeing you lots in the coming months and years as the programme rolls out. Thanks for joining us, Tracy, and also Richard, Heather and Andy for your presentations.